Okay, so it's 5 p.m. Geneva time. Welcome everybody. So this is Learning Innovation in Practice. And my name is Maria Monzon. I'm from Argentina. So I'm going to be the moderator in this. I'm going to share with Cecilia and Katia very quickly. So when we start, please, we are asking you to type your name and the city and the country that you're connecting from in the chat window that you can see on the right. The idea here is to participate actively, to listen, ask questions in the chat. No question is full. We want to hear it all. We do ask you not to press on that blue button on the top that says ask to share audio and video, unless that we explicitly tell you to, because it will disrupt the session and it might cause problems to the speakers. So if you already participated in another session, it's mainly the same. We will hear the presentation from our speakers, and then some invited scholars are going to share their stories of local learning solutions from the field. We're going to have Q&A at the end, but also we can do it at the same time in the chat. These are our speakers, proudly presenting Katia Shemionek, from Gavi, and Cecilia Werthmuller from Gavi. Sorry for the pronunciation. I'm sure that's not correct. Please. I'm going to invite them to introduce themselves, and then we can go ahead. So I'm going to stop sharing here so you can see our presenters.
So Maria Fernanda, this means that we should take over from now, yeah? Okay, great. So let me share my screen, because I'm always very nervous. If this doesn't work out, then I'm in trouble here. All right.
It's good.
Okay, all good? Yeah?
I can see it at least, yes.
Okay, so I'm Katia Shemionek, that's how you pronounce it correctly, and I'm accompanied by Cecilia Werthmuller. Coincidentally, we are both Germans, and we work in the Gavi Secretariat in the Health Systems and Immunization Strengthening team. What I wanted to do is give you an overview about Gavi's new thinking in regard to health workforce. What we learned in the past is that we invested quite a big amount of money in countries' health workers, but we really didn't have a good understanding what are we getting out of that. Our approach is the right approaches. Very often we understand there are not enough vaccinators, there are not enough health workers. So you all know, because you know health systems very well, the area of health workers and health workforce is a very difficult one. So let me just introduce you to our current thinking, and then Cecilia can introduce herself and her role in the Gavi Secretariat and give you some of the more concrete examples. So what we have been thinking through is that in principle, you need to address 5 important pillars within the remnant of countries' health workforce. Number 1 is you need to have a sufficient number of frontline health workers available. And I say frontline health workers because I mean here the facility-based health workers and the community-based health workers. I do not mean the API manager, for example. This focus is here really on those who are in the communities and in the facilities to meet the country's need to deliver primary healthcare services. We all know very often countries can simply not afford their health workforce, or the health workforce is migrating to other countries with better salary. So the availability of sufficient health workers is a key criteria to really work on this subject. Similarly, very often we go to countries and then we are being told we do not have vaccinators in the north of the countries. We do not have vaccinators in the remote area. And then you ask, but what is your overall number of health workers? And very often, in addition to the economic constraint that country cannot absorb all the health workforce in the market, very often, and you know that health workers are concentrating in the urban areas where they find work and not necessarily going to the urban slums or to the remote areas. So these are very important ingredients, but it's very difficult, specifically for an organization like Gavi that is relatively small, to to solve these issues. So more importantly for us is that the health worker needs to have the right technical, functional, and communication skill to perform immunization safely, of good quality, and to make, and this comes in the next two bullets, to ensure the caregiver that they are in safe hands, that the caregiver understands the importance of vaccination, and the caregiver also understands that he or she should come back. What we observe very frequently is that health workers are being trained very often in a top-down classroom traditional approach, but then being left alone. So it's also very important to help health workers to continuously improve their performance and to maintain their performance. And most recently, we have put a lot of effort around the thinking, what about the accountability of a health worker towards his or her community? Can we not help, and we have seen it in a number of countries, establishing these accountability mechanisms through, for example, involvement of the community in the planning of immunization services, in the mobilization for outreach sessions, and so forth. And I mentioned that in the session earlier, we talked a lot about demand for immunization. The health worker needs to have the right attitude and behavior so that the caregiver can feel, I can trust this immunization service and I can come back. So altogether, our effort is targeted towards improved quality of services, equitable access, and I said that in my earlier presentation, the focus of the new Gavi strategic period is really to reach out to the most vulnerable and missed out communities to ensure there's equitable access to immunization across a country, and as such to reduce the zero-dose children, which are just a marker for us to understand where are the missed communities. So this is just a small overview how our thinking is, what our investments are about. Our investments are small in comparison to the needs, specifically in the area of countries' health workforce. So we need to strive towards being catalytic, practical, and innovative. I have introduced in the previous presentation our innovation catalog. There are a lot of new things that very often come from the country that are so successful that we cannot invent them. They're just there, but they have the potential to be scaled up, and Cecilia will speak about a few of them. We also need, and this is very sensible in the area of health workforce, towards sustainable change. We cannot always supplement or replace salaries. At some point, countries need to carry the health workforce, and we need to support these efforts towards increased sustainability. Of course, specifically when we talk about health workforce, we need to be gender responsive and transformative. There are very often gender-related barriers to female health workers, for example. We need to work in complementarity and integration with what other financiers of the health sector are doing. We need to align specifically in this context to national HR policy. This, for example, means that we would not, in rare cases, pay incentives or what have you at a rate that is much higher than the national level already has planned for. And this is very difficult in learning. We need to drive towards data to be able to measure our impact. So this is just in one slide, and you see the size of the bubble in rare occasions when you really do not have the health workers in place to reach out to the missed children. We provide time-bound salary support to health workers. This is similarly to retain health workers in remote areas for a time-bound scenario. On the long term, this needs to be taken over by the government. Gavi does not have the means to do that on the long run. But more importantly, which is the focus of this presentation, is to think about how we can engage in more efficient, impactful learning initiative that move away from a traditional top-down classroom training where you train somebody and then you leave him or her alone and this is it. We don't want to continue because it has been proven also in the literature. There's ample of research on that. This stand-alone training does not have a lot of impact, because it needs to be coupled and paired with supervision, mentoring, peer-to-peer learning, all these other very strong support mechanisms to help the health worker to continuously perform and also to self-assess his or her performance. And we spoke about the behavior and attitude. Interpersonal skills has to be integrated in any learning. It cannot stand the technical content here and then how you deal with your caregiver there. It has to come together. This is absolutely critical. And as I said, because Gavi is small, but we have a voice in the global public health arena. We need to push together with other financiers and partners to really, especially in this area of health workforce, to continuously learn what we are doing and to improve and to transform what we are doing. So we have currently a small support from the Rockefeller Foundation, and I highlighted this because I like the title is, and this is what the whole Teach to Reach conference is also about, to support countries to adopt innovative and disruptive approaches to transform learning and performance management of health workers by leveraging digital technologies. And this is for me, this is really powerful, and this is what we try to do. We have already started with a mapping and assessment exercise of existing new approaches, and we have a very strong service provider who's helping us with that. We have another partner who helps us scaling up approaches that have been proven very successful in the context of COVID-19 to make the health work fit to deal with the pandemic, and we want to learn from that, and we are also working very closely in that context with WHO, UNICEF, the Global Fund, and other expanded partners, because we also need to harvest what is all happening there and build in our long-term strategy. So let me hand then over to Cecilia with some of the details, and Cecilia, you let me know when I move the slide. Over to you.
Thanks, Katja. Yeah, brief introduction. I'm Cecilia Wertmüller. I'm with Gavi as well. And my background is in learning science and economics. I've worked in the education technology space for some time. And now at Gavi, I'm kind of driving that learning innovation work and understanding what is needed to actually make it work in the field and on the ground. So very thrilled to have this presentation here. So I will talk about basically how we currently think about learning innovation and give a few examples, as Katja mentioned, and then I'm really curious to learn more about sort of what is already happening. As Katja mentioned, there's often so much like really coming from the practice that that we cannot think of. Yeah, I think Katja, next slide. Thank you. So let me start with what we mean when we talk about learning innovation. So here we have, basically, we're thinking about 3 different elements. One is learning science and methods. As Katja mentioned, there is so much that we know about what works and also what doesn't work. And it's not necessarily implemented in practice. So yeah, so that's a key part in learning innovation, is using what we know what works. Then learning and teaching technology. So this is really about how we can use tools and technologies to implement the methods, the learning science methods, more effectively. They can be used, they don't have to be used, really. And then there's learning and impact analytics. And this is really sort of what insights can we draw from the learning data, from learning technologies. How can we link them to outcome data, so to actual health outcomes? And how can we also individualize learning more? And I will talk about each of these 3 in the following sections. Next. Yeah, so as I mentioned, we know a lot about how humans learn. It's actually both adult and younger learners. There are a few differences, but they're not huge. And they have been shown to be effective in different contexts. I will not touch on all of them here because it's, well, quite extensive, but I will give a few examples, for instance, for low dose, high frequency, just-in-time learning, and drilling micro skills and feedback in a moment. Next. Before I do that, I think it's important to stress that applying these principles and this knowledge really means a new view on learning. It's basically a shift from focusing on the input, sort of what Katja mentioned, top-down classroom. What do we want to teach? What content do we want to give? And shifting to the learner at the center. What do they need in order to change a behavior? What do they need in order to do their job well? And then what are the impacts that we want to see? What are the changes in the outcomes that that we're training for, really. And in healthcare, there are always outcomes that we're looking for, right? So next, looking at a few examples of applied learning methods. One is low dose, high frequency. And this is basically a model where learning is refreshed frequently. For instance, every week. As Katja mentioned, training once and then leaving people alone is really not that helpful. It's better than nothing for sure, but it has huge limitations. And so instead of, as you see on the left side, training maybe every other year for 2 days, we can train once in like a larger chunk and then keep that knowledge up to date by frequent but very short interventions. A few minutes a day, or a few minutes, 15 minutes, 10 minutes once a week. Really repeating critical skills and critical knowledge to ensure that it remains above the sort of critical threshold is really, really effective. And this has been shown in one example here from Tanzania, where 8 hospitals in the neonatal units and the liver units shifted from that left model to the right model. And they could reduce within a couple of months, 6 to 9 months, newborn mortality by 47%. And this change actually persisted. Next. Thank you. The next one is peer-to-peer learning. Basically, it's practicing in pairs of learners. So one learner performs something, tries a process or something, and the other person evaluates. Important for this to work is that it's very structured and guided. So there need to be certain standardized contents, checklists, so to ensure that the evaluation is correct and that the feedback is correct. It has been shown, though, in research that this can be done such that it just works extremely well and people's performance improves a lot. And why is this so effective? Because learners can practice without the presence of a teacher. So they can continue until they achieve mastery in a certain skill, which also gives confidence, which enhances transfer to practice, and also reduces the load, the energy that is needed to actually perform the task, because it's become basically second nature. Next. And then we have just-in-time learning, which we could also refer to as on-the-job learning, which most of us probably do. It basically means that we learn because there's a need right in front of us. And when we learn this way, our brain is basically primed to absorb whatever comes next. And because then we apply it right in practice because it arose out of a need, we also transfer it, right? Apply it to our learning, to our work, and thereby overcome that gap between learning and clinical practice. So this is really powerful for effective learning, very efficient, with little time, high impact, and for transfer of learning into practice. Next. I think we skipped that one. There are a few additional examples, but I think we will hear more from the audience anyways. So going over to technologies and tools for learning and teaching. So here we have we think about different ways of using technology for learning and their effectiveness. And at the beginning, basically, it's about digitizing and adding a few features. And this is here on the left side, enhancing. And then on the right side, it's really where we create new and transformative learning experiences. And already on that substitution, the very left part, where we take contents and make them available on a device, and it can be a very basic phone, really, without internet connection. We increase access, we increase scalability, we can add practice. So this really is already a game changer. Next. Yes, so adding to that, learning technology really doesn't need to be high tech to be effective. And I really want to stress that because the word learning technology can sound very, very high techy. But really any tool that aids learning is in a way, learning technology. So here you see at the top, sort of a continuum from low bandwidth or no bandwidth, really, no connection, to 2G, which is basically phone signal, doesn't need internet, to 3G, like medium bandwidth. Maybe we also have occasional access to the internet and then go offline again. Up to, which is of course the easiest, but not available everywhere, or in many places not available, high bandwidth. And at the bottom, we have examples of what we can do in learning with these different devices and connection combinations. And really already even with offline, many of the principles that I mentioned can be implemented. Just-in-time learning might be a bit more difficult, but really low dose, high frequency can be done without connection. Also, peer-to-peer learning can be done without internet connection. With a feature phone, then you can have message-based and voice message-based access to information, checklists, interaction, even data capture. And then, of course, up to the right hand, there's much more that we can do, like communities of practice, video, audio-based remote supervision, and all of these things. But really, on all of these levels, there's many opportunities for improvement. Of course, there's limitations in terms of when we need tactile things and sort of physical, need to feel something or practice something with an item. That's another chapter, basically, and a bit more complicated, but in some ways still possible. Next. Perfect. Yeah. So now over to learning and impact analytics. Here, I just want to touch on sort of these three opportunities. Katja also mentioned understanding sort of what works, what doesn't work, where is more support needed. So with learning data, and learning data means sort of data captured from devices while a learner learns, and impact data means sort of the outcome. We can improve individual learning and team learning and the experience and the outcome of learning with the help of data. And that can be through analytics, through instant feedback, and through adaptivity. In the middle, it's about improving products, learning products, really. So basically what we can do with all these products is try out different ways to present content, different exercises, and see what has the best effect. And then implement that and scale that up to other people. And on the right-hand side, this is really the opportunity to aggregate learning data, to understand, for instance, competency levels by geography, and then link that learning data and that competency data to actual health outcomes, to understand what is needed, what works, and what else needs to be done, basically. Of course, this shouldn't be on an individual level. We want to protect the learner. So this is really thought to generate insights. And while not all areas will be connected and have access to this data, there can be so many learnings derived from even some regions with access to such data that those learnings can then also be, in some cases, applied. Yeah, and these are opportunities. So we're not there yet for sure. This is aspirational. Yeah, and I think I will stop here. I guess I'm basically out of time. And this is just how we think about innovation and learning and about sort of transforming learning. And at the same time, of course, innovation is only as good as the implementation. And this is really where you all are the experts. And yeah, so Gavi really strives to invest more in this innovation. And I'm really happy and excited to hear sort of your perspectives and practical experiences, especially now during COVID. What worked? What barriers did you encounter? Yeah, and of course, any questions. With that, I hand over. Thank you.
Well, thank you very much to Cecilia and Katja. Go ahead, Katja, you wanted to say something? Cool. I was just reading two questions that were in the chat that maybe we can go through those and then go back to see with the slide deck other for our audience. So Carolina Novaro asks, what kind of nudges are useful for frontline workers to do what they need to do better?
Can you repeat that?
Sure. What kind of nudges, and she puts the comments, are useful for frontline workers to do what they need to do better?
I would say that depends a bit on what change is needed, really. So there can be things like what has been shown to be very effective, for instance, are things like checklists. It sounds very simple, but it comes from the aerospace industry and from Formula One, I think, was then introduced into surgery. And it can just help to ensure every single step is followed and nothing is left out. This could be one thing if things pop up. I mean, if we talk about nudges, it's really about sort of putting it where people see it, and making the right choice or the desired choice easier. And that would be one example, but I'm sure there are many more.
Please, if you permit, there was a previous question before that from Sohini. She wanted to find,
I'm seeing it.
Yeah, she wanted to find out. Thank you. In your experience, what is the best way to motivate learners to apply their learning other than monetary incentives?
Yeah, that's a very good question. So I think first of all, it's a question of whether it's actually motivation or whether it's about the skill. So if learning, as Katja also mentioned, is done top down in a classroom setting, often people haven't learned the practical skill, right? And it's out of context. So it's very difficult. The barrier is really, really high to actually use what we learned in that classroom and do it in a completely different setting, in a different mode, because now we have to apply a process. Now we have to use tools, which is very, very different from reading or from doing it once, maybe in a practice session. So I think here these methods that try to integrate learning and bring learning into work, into the clinical practice, helps make it so easy that there isn't that much motivation needed, really, because it becomes natural. Does that make sense?
Yes, it does. Another question from Burema Kabore. It says, my question is Gavi ready to fund all these methods in the same country if local actors in different contexts choose one or other of them, or one country must choose a single method of learning?
Katja, do you want to speak to that?
Yeah, of course. I think I spoke a little bit about the grant making process before. How we operate is that the country stakeholders are sitting around the table and then discuss what would be put forward for funding for HSS. But I think it's very important because you all come from countries where I understood you have already something like a teach to reach community of practice. It would be very important that your leadership is aware of what is out there, what is most efficient or effective, and you can, with support from our end or our alliance partners, also prove, as Cecilia just said, what is the most efficient solution, and then bring it forward to the table. The table means put it forward for funding, because it has to be embedded in an overall approach to health system strengthening and to improve the performance of the health workforce. So this is not up to decide, but you should make the case with the data that Cecilia just spoke about.
Thank you very much. Another question from Sohini again. Are you seeing the use of gamification in current capacity building interventions? Will you share your experiences?
So in current capacity building, I haven't encountered so much, but also we're kind of at the beginning. I've seen gamification in many, many different contexts, and with varying results, really, because there's a form of over gamification that keeps the learner sort of on a program, but keeps them focused more on collecting a badge or a point without actually adding learning. But it can be very helpful in bringing learners back to an application, certainly.
Another one from Stephen Kiluva. Any performance-based incentives for health workers to learn and practice?
Can you say that again?
For sure. He asks, any performance-based incentives for health workers to learn and practice?
Is the question whether that it is helpful to have performance-based incentives?
Like that.
Yeah. So, I mean, it depends is always a bad answer, but it depends. There are ways to motivate by external incentives, but these have limitations, and they can go the wrong way. That will have to be revised and looked into more deeply. I think that there isn't really a general answer.
I think we also still learning, Maria and Cecilia, we are doing in some countries performance-based financing. As you know, this is a performance of a health facility per se, but with Cecilia and within our team, we have already started discussing how we can incentivize health workers. This can be financial, but this can also be non-financial. I really have seen some wonderful examples, and you have a health worker that is really performing outstandingly to share his or her experience in a national meeting or in international forum. So we need to think about that, but it's extremely important. You are absolutely right, specifically in our countries where the civil service salary is so low. So we have to think about that. And as Cecilia said, if we can link this to some data, of course, keeping protect the individual, I think we can do a lot around that. So this is why the data also is so important.
Yeah, and maybe to add on to that, I think why I'm hesitant to sort of make a clear statement. I think there are also like dangers, especially when we talk about low salaries and things, of like negative ramifications of linking money to performance. In a way, of course, it has its upsides. We all know that, but we also really want to avoid the negative impacts here.
Great.
Thank you.
Go ahead, Charlotte. Go ahead.
Okay. Yeah, I just wanted to say, Katia, just because I have wanted to add to the question that what kind of incentives could you propose? So answer the question, but I see a question here from Carolina Danuvaro again. And Maria, if you permit, I asked Carolina, she's from WHO. If she could join us here on the panel, because I think she may have some thoughts with her experience with training on new things that they are doing in that light. So, but just to read the question that she asked, are there experiences where immunization people have joined forces with universities to have specialists help with workforce development? And before turning to you, Katia and Cecilia, I would have really wanted to listen, to get answers to this question from participants in the room, because they are part of the scholar community and they have been doing lots of things on the field. Unfortunately, many of them are having connectivity issues because they are dropping out of the session. So I just do hope that maybe Joseph Mbaringuki, that's here with us, could unmute himself and share if he has any experience with what they are doing on the field in order to improve training. And then we'll turn towards you, Katia and Cecilia, to address Carolina's question. And we'll end up also with Carolina. And by the way, you're welcome, Carolina. So Joseph Mbari, please, can you unmute? And Joseph Barry Gugi, okay, yeah, please unmute. Yes.
Yeah, I've unmuted myself.
Okay, please go ahead. Yes. Can you just introduce yourself and then share your experience?
Joseph Gugi from Kenya, Murang'a County. In the training, we are using the old methods. where we talk to the caregivers about the importance of the immunization, because we don't have the new gadgets and it is becoming an issue. Thank you.
Christian, how has the COVID-19 pandemic affected the way you offer training within your context, and what have you been able to do about that?
It has really affected us because most of us, we are having problem with technologies and they are not available, and also most of us, we don't have the skills. So the training is having problems. And you see with the COVID-19, people can't come together. So it is really a challenge, and it is really affecting us.
Okay. Okay. Thank you very much, Joseph. So now I'll turn towards you, Katia, and then we'll get to Carolina.
Can you repeat, or Cecilia takes first? I was busy writing something in the chat.
Okay, so the question was, are there experiences where immunization people have joined forces with universities to have specialists help with workforce development?
Sorry. Yes, that question. This question is absolutely pertinent, but I think it is due to our own a little bit of silo working that this hasn't happened, but this is exactly the idea. The idea is to have immunization specialists to contribute to the curriculum of the pre-service training of midwifery, nursing, what have you school, of course. But in practice, we all do in service, but this is absolutely great question. So I'm sure Carolina has some additional views on that.
Okay, Carolina, please.
Thank you. I was just had an experience when about 4 years ago when we were going to do a training for vaccination coverage surveys, and it was eye-opening when I started working with the Geneva Learning Foundation to understand how much the learning sciences have advanced and how you understand what works and doesn't in trainings and how to do things differently. So I wonder, I mean, we do things with specialists, right? We have the phone company help us with our phone. So why we are not working with specialists in learning to develop our own programs as well, in addition to contribute to the pre-service and people in, you know, when they are studying to be nurses, when they are studying to be health workers, when they are studying to be doctors, and how can we do that more? Just a quick example, Chile, for example, hires and works with the university in marketing career for their marketing campaign for the influenza vaccination campaigns every year. And you know, the university produces the marketing campaign to call the population to get that vaccine. And I think it's a very unique idea, but I wonder if that's happening or why not.
Thank you, Carolina. And one thing I've also learned from scholars that took part in the COVID-19 Peer Hub is that we have some members of the community that are actually university lecturers and professors that have been called upon to look for new ways on how to improve upon training or how to give out training in a way that could lead to more improved results. And I'm really glad to notice that there is a lot going on the chat concerning incentives and also technology. Interesting question here, Cecilia, from Joyce Muridi. She says, how many people even feel, I'm sure he was responding to a comment from Joseph, how many people even feel health workers own the technology and know how to operate the gadgets? I think you have a real challenge there. What other options will you use to inform the population or even to provide training to field health workers? And I may want to ask you, Cecilia, to revisit that a little bit, probably for the benefit of those who joined the session a little bit late.
Yeah, sure. And thanks for that question. So I think, so during the presentation, I briefly spoke about sort of the different levels of technology that can be used. And also in our conversation internally at Gavi, we're really thinking about all the different sort of categories of technology access and connection and connectivity. And of course, there need to be solutions for all the different levels, right? It doesn't work if it's only for high-tech smartphones and 4G connection, not at all. I think there is, as I mentioned at the beginning, sort of there are the learning sciences, as Carolina also just mentioned, that have a lot of potential that don't really need the technology. It's really about how learning works and how we get from top-down classroom once a year or once every other year to integrated learning into practice. And then there is the middle ground where there might be basic phones. And I'm not sure whether you're referring to no phones at all or basic phones, and sometimes a signal, or maybe the ability to do text messaging, where it's really, there have been interesting examples actually from education, from like formal education. For instance, with ENESA, which is a school started out of Kenya and Ghana. And they work only on feature phones. Like, they don't need internet access. They work through messages. It's school support. It's not a full school, it's school support. So they basically can provide whole Wikipedia articles. And there's the option for voice messages if people have difficulties reading. And so there are many workarounds really that that don't need like gadgets, like high-tech gadgets. And of course, then there is a question of cost of messaging, and there are also interesting examples that aren't scaled yet. But for instance, in that ENESA case, there's a collaboration with the telecommunications company that ensures either low cost or no cost to questions or SMS, text messages that are being sent to a specific number. So there are different ways to address that and to think about it. That would obviously like require like thought out larger solutions. In a smaller case, so if we don't think about a large scale solution, I think it's really about materials and about sort of on frequent learning in small instances.
Thanks again, Celia. And just to share with participants in the room, I'm sure there will be a session on pivoting training during the pandemic. And I'm sure, and one thing is when we go through some of the qualitative data that was shared by participants, a lot of them actually talked about doing training using the use of WhatsApp, but also the use of short mail, SMS, like you said, Cecilia. So it means that with the pandemic, a lot is going on the field as people are trying to adapt even before the guidelines come up and all of that. People are already trying to adapt as much as possible to be able to continue offering what they used to offer before, in spite of the technological difficulties that they may face. Okay, and I see there are many other people that are sharing their experiences in the chat. There is an appeal here from Effiong Udobong. He said, I appeal that Gavi should consider continuous strengthening of its support to civil society platform on health, to continue the good work on advocacy, communication, and social mobilization on health, including immunization, especially during this COVID-19 period. Katia, what do you think about that?
I can just say, yes, of course, we have increasing involvement of our civil society organization, expanded partner. We just had developed a new strategy to engage with civil society. Is absolutely important in this time of the pandemic. We have seen that we have regular meetings with the civil society steering committee and partners to understand the learnings from the current situation, which is, of course, very pertinent for this topic. So I also see there's an interesting feedback from Nigeria on the use of U-Report. So, of course, we are highly interested in how these pieces work, to what extent these have been successful. So if maybe the participants can share some of their additional innovations that have been proven to be successful during the last year would be very good for us.
Okay, and I think it's already, that's 5:55 p.m. Geneva time, and the time has gone by so fast, but I think we're supposed to be going for networking now. There is this last question from Adriana that says, is there a place where we can go to learn person that is, let me see, where we can go to learn more about different immunization learning strategies in countries that are funded through Gavi HSS. So she's probably talking about resources. Here, some links, Katya, Cecilia.
As of my knowledge, currently there isn't, but that's certainly something that that would probably develop as part of that project and that new strategy. Katya, do you have anything to add? So that's a really, really good point, Adriana. Thank you.
Okay. I really want to thank you all for your active participation in the session, and it was so wonderful to see how much we were engaged and the wonderful comments you left on the chat concerning the clarity of the presentation. So I'm going to turn right now to our speakers for a final word. And I do hope you get to enjoy networking, and perchance if Cecilia and Katya go for networking, they may you may be able to get to them to ask one or two questions. So I'll turn towards you, Cecilia, and then Katya for the closing word for this session. And I want to thank Maria for the moderation and the rapporteurs that have been taking down the notes.
Thank you very much. Thanks very much, Charlotte. Also, thank you all very much for the active participation and the very interesting questions, because we do learn a lot from these questions, right? So yeah, so I think as I understand it, this project is really timely, and using innovation in learning and technologies where possible is very timely. And I hope very much that we can engage further also in the future to learn more about your work and the needs, so we can really address what is needed and develop something that's very practical and helpful.
Yeah, just to add, we do not yet have all the solution on the table, but I think I'm just remembering when we started digging a bit deeper of what are we funding as Gavi, what are we funding in terms of health workers, and we just realized we need to change gear here. We need to really learn what we can do better and then do it better. So now we are in the phase of we understood we need to learn better, and I'm very grateful to be in this meeting, because we also need to learn from you. I'm also very grateful that we found somebody like Cecilia who can help us with all these elements. This is a shift. It's not only a cultural shift in training on learning, this is a shift for an agency like Gavi, funding agency. And so bear with us. We do not have the solution on the table, but we work across the alliance, and this will come soon. And I just really hope that we can all stay in touch, learn from each other, and see you in the discussion for any of your country when it's about planning for better HRH investments. So thank you very much.
Thank you. You're muted. There you go. Now we can hear you. No, so muted again. There.
Okay, so I'm just sharing the link to the networking on the chat. So if you want to get to meet somebody with whom you can discuss for 3 minutes, and if you want to extend the discussion, both of you can agree to take the discussion further. So just click on the link and then you meet. It's just a random meeting. So you just get to be able to meet someone with whom you can chit chat. You may be lucky if Cecilia or Katya or Carolina, they decide to also network, and just have a nice time. If you want to stay back in the room and continue to share your experiences based on what is happening in your context, feel free to do that. This was, and I really want to thank Gavi. Today, we actually called it the Gavi Day because we have had 4 sessions with Gavi, 2 in the morning with the Francophones and 2 now with the Anglophones. So we really want to thank Gavi, Katia, Cecilia, and Eric that was with us in the morning for the French sessions, for taking out the time to come and share with us all that which Gavi is doing as far as health system strengthening is concerned, and of course, learning innovation. So really great, and looking forward to reconvening tomorrow with a plenary and more workshops and sessions for tomorrow. So bye for now.
Bye.